All right, so let's go ahead and get started. My name is Joe McClernand, and I'm a professor of psychiatry and behavioral sciences here at Duke. I'm also director of the addictions division in our department. I'm also one of the co-founders of mHealth at Duke, along with Bernard Femler, who's taking his seat now. Bernard and I gave this baby away to Gary and his team a couple years ago. And it's great to see that she's growing and thriving to this day. The topic of this next session is usability. And we've already heard a lot about usability already this morning. I really liked what Michael said this morning about how we only notice these technologies when they're not working. And so our speakers today, I hope, are going to be providing some insights on how to make our healthcare solutions work better so that they do become more invisible. In preparing for this session, I looked at a few papers. There's a lot of work that's being done on usability right now, and there was one that really struck me. The investigators gave healthcare apps to patients and their caregivers and asked them to accomplish various tasks with each app, including things like open the app and register as a new user, or go to a screen and find out information about a certain topic. And what they found was that participants could only complete 43% of tasks necessary for using the apps without the assistance of study staff, and that none of the apps that were tested had clean, simple interfaces with large buttons and easy to use, easy to follow instructions and navigation. So there's clearly a lot of work that needs to be done around usability. Usability raises a lot of questions. Who are we designing our mobile health interventions for? We've already heard some discussion of that this morning. What design features increase or decrease patient use and engagement with our solutions? And how do we better design and engineer solutions to increase engagement and improve efficacy and effectiveness? And how do we do this for the diverse patient populations that we're hoping to help? So we have a great series of speakers that will no doubt shed light on all of these questions and the challenges associated with usability. Our first is Dr. Sarah LeGrand. She's an assistant research professor at the Duke Global Health Institute and the Center for Health Policy and Inequalities Research with a doctoral degree in health services research. Her research focuses on HIV care and prevention with a focus on mental health and substance abuse-related interventions. And today she's going to present on participatory design process. Great. Sarah?
Thank you. Thanks so much, Joe. All right. Should I just push some buttons? They're big buttons. That's what I thought, but I didn't want to take the chance. All right, so good afternoon, everyone. So today I want to talk a little bit about using participatory design to develop usable digital health interventions. And so using participatory design can be useful both for helping evaluate the usability of your solution, as well as it can help increase the likelihood that the solution you develop will be usable. When we think about participatory design, we're essentially thinking about engaging multiple stakeholders in our process of design. And often, I've been really encouraged actually by all of the conversation that I've heard today, because I feel like most people are really clued into this idea of using a participatory approach. But sometimes when we think about our key stakeholders, we think about our designers, our developers, our clinicians, our researchers, but often we don't include the end users. And so what I would like to contend is actually the end users are experts and provide a level of expertise that none of the rest of us have in developing usable interventions. All right, so I do just want to quickly say that I'm representing a much larger team of researchers. I'm part of the BAT Lab, or the Behavior and Technology Lab, that combines researchers from both UNC and Duke to develop digital health interventions. And the focus of our work is on reducing disparities in HIV infection as well as HIV disease outcomes. We work primarily with adolescents, youth, and young adults who are sexual and gender minorities, and oftentimes racial and ethnic minorities. And we develop theory-based behavior change interventions using tools such as the internet, smartphone apps, as well as virtual reality. So I wanted to talk a little bit about the value of using a participatory design process, and I really want to focus on the end user in this process. Of course, it includes all stakeholders, but really what's the value of including our end users? First is to really understand the problem and the context from their perspective. So particularly with the context, so we know that many factors influence behaviors, and so understanding what these factors are can really help us design better, more useful interventions. In addition, it's important for us to understand preferences. And for us, we work with youth, and we know that preferences around features for interventions as well as platforms change at lightning speed. So it's really important for us to understand the preferences of our end users. And by understanding both the needs, the context, as well as the preferences, and in addition to adding on additional participatory design features such as usability testing and pilot testing, we can really help increase the likelihood of developing a usable and useful and relevant intervention. And finally, we have the opportunity to empower our end users. And for us, again, we're working with marginalized youth. And by giving them a voice and giving them an opportunity to tell us what they see as the problems and help contribute to the solutions can be very empowering. So I wish I could talk about all of this in great detail, but I only have a short period of time. We have wonderful other speakers here. But again, you know, in talking about the participatory design process, really emphasizing the end user here, there are multiple ways and multiple points in which we can engage our end users in this process of designing our interventions. And so these are just some of the ways. And one of the things, again, I'd like to talk in detail about them, but I really want to highlight that's important here is that so many of the ways that we can engage individuals in our design process can happen using the digital tools that we all use in our work. So we can engage participants using online focus groups, or we can use video conferencing for focus groups, or for co-design workshops. So there are many different ways to engage users. And for us, again, this is really important because we're working with highly marginalized populations. They may not feel comfortable if it's a young gender minority individual with being in a space and being open about their identity if they're not open in public. So by combining both in-person and online participatory processes, we can really gather the information that we need to improve the likelihood of success with our interventions. So I wanted to quickly talk about the participatory process that we have used for one of our interventions. We have many, and I will say with every intervention that we design, we always use a participatory process. So one intervention we have is a virtual reality intervention called Tough Talks, and it is an intervention designed to give a space that's realistic and safe for HIV-positive young men who have sex with men to practice disclosing their HIV status to others. We know that many people who are positive after diagnosis continue to practice unsafe sexual behaviors, and so increasing skills and communication around disclosure can help them disclose to their intimate sexual partners. And so with our participatory process and this particular intervention, we used a combination of focus groups that included elements of brand testing or design testing, as well as co-design workshopping, as well as usability and pilot testing. And so I just want to talk briefly. There's so much to say about what we learned through this process, but just briefly from some of the findings from our focus group brand design testing. We learned several important things. First of all, just from simply the focus group discussion, we learned what the disclosure experiences of our target population have been like, and barriers and facilitators to disclosure, which help inform our intervention. And with our brand testing component, first we had the hot or not kind of brand design testing. So we had a concept and we wanted to present it to get feedback. So what we were trying to do here is to create our avatars for our virtual reality intervention. And so we presented a variety of models. We kind of had this attitude that the hot would be the way to go. You know, we have some hot avatars and people would feel comfortable, you know, practicing these disclosure skills. And what we quickly learned was that that didn't work for many of our participants. For one, they felt that that wasn't a realistic scenario for them. So they would rather go with not than hot. And also, some would feel intimidated in trying to practice disclosure to a hot avatar. So this is really critical. So we went in with this assumption and quickly learned by engaging our participants that we were wrong. Okay, so the other important thing was the backgrounds for our virtual reality environment. Again, we had this idea, we had these 4 scenarios, environments that we had created, and learned that only one of the 4 that we thought would be the perfect environment for practicing disclosure were the ones that our users were comfortable with. And lastly, we did some role plays, and the dialogues from those role plays were actually used to create dialogues for our intervention. So again, I could talk forever. If any of you have any questions about participatory design and the way that we've used it in our research, I'd be happy to talk to you about it, but I do think it's a very important strategy for increasing the likelihood of developing relevant, useful, and usable interventions. All right, thanks.
Great, thanks, Sarah, and sorry you had to rush so much to that. I want to make sure we get to everybody's talk. And I think we'll just go ahead and do questions after all the speakers have had a chance to be up here. All right, so our next speaker is Dr. Dory Steinberg. Dory is the Associate Director of the Duke Global Digital Health Science Center and a research scholar and faculty member in the Duke Global Health Institute. Her research focuses primarily on technology-based interventions for weight control, dietary change, and chronic disease management in adults. Today she will present research on designing a usable dietary self-monitoring app. Dory?
Great, thank you so much. I'm thrilled to be here to talk with you all about some of the work that we're doing at Duke Digital Health. And just to kind of give you a little background, similar to what Sarah just did, that Duke Digital Health's been around for a couple of years. It's directed by Gary Bennett and housed in the Global Health Institute. And what we're really trying to do, our mission, is to try and leverage technologies, particularly for weight control, and how we can best improve engagement in these obesity treatment programs, but particularly for medically vulnerable, socioeconomically disadvantaged populations, and I think that is just a key point I just wanted to make. And in the last panel, you heard from Harriet Burns at Piedmont Health, and we've worked closely with Piedmont and their leadership in order to design and test some of the interventions that we're doing. So what I'm going to present on you today, just kind of keep in mind that this was tested in a population that tends to be lower income, medically vulnerable, sicker population. Okay, so with behavioral obesity treatment, there are many elements in these interventions, but the cornerstone or the main, most effective behavior within obesity treatment is self-monitoring, or you can call it tracking, or you can call it quantifying yourself. But other than that, we know that when individuals self-monitor, in this case, they keep track of everything that they eat in detail, what they ate, the amount that they ate, and then they take the next step and then calculate how many calories, how many fat grams, or whatever nutrient they're interested in. They do better. And the goal here is that they add up all these numbers and then figure out sort of what their caloric intake was for a day, compare it to a goal that was set for them, and then make changes if needed to achieve that goal. But as you can imagine, and some of you probably have experienced this yourself, this requires a high attention to detail. You need to know that you had a teaspoon of mayo and not a tablespoon. There's a big calorie difference there. And you need to be able to engage in complex numeracy tasks, which, for even those who are highly educated, this can be a very difficult and burdensome thing to do. And not surprising, the burden is fairly high with this approach. And this approach is still used in practice, this paper and pencil. It's used in research, so it's not something that's antiquated. And this is the pattern that we typically see. So we see a sharp decline fairly often, early on into a program that slowly declines over time, such that around 3 months in, only about 30% of people are really truly engaging in this important behavior. So our challenge is to try and change this trajectory so it doesn't just decline, as this is seen over many, many studies, and even in the commercial apps as well, to really make it more of a stable self-monitoring engagement so that we can really see the outcomes that we want to see. Because what we know, though, is that the more you use, the more you lose. There is a linear association with self-monitoring, this type of self-monitoring, and weight loss outcomes. There's no question there. The research really supports that. But this paper and pencil approach, as you can see, is difficult. So can digital health help, is the question. And some of you are very familiar, there are thousands of apps out there that are essentially trying to translate this diet tracking into a smartphone application with the idea that it can reduce some of the burden. And it does. Like, this is a screenshot from MyFitnessPal. You don't have to take the next step of calculating how many calories are in the food you're eating. It's already there. It does it for you. But you still need this high attention to detail. This type of approach can still be burdensome. I mean, how many in the room have actually tried using MyFitnessPal, Lose It, Weight Watchers? I mean, and how many are still using it? Okay, we got a couple hands, great. So we got some high, but and you're in that smaller proportion of people who continue to engage in this. It's not that it doesn't work, it's just not working for the masses, really. And so these apps, and we've heard some of it today, are getting a little more sophisticated, having more features, such as just taking a picture of what you're eating, and then hopefully the app can infer, based on that picture using machine learning or whatever technology, what how much calories what you're eating, and estimates around that. Or you can just scan a barcode, so you don't even have to insert that I had a granola bar. It can just do it for you. And then lastly, as we've heard, it seems that's the common theme, that some newer technologies using Alexa, where you say, Alexa, tell Tracker I had a turkey sandwich, and then they do the work of entering that into the app. Of course, we eat throughout the day, so you'd have to have Alexa with you at all times to really get an accurate picture. So, I mean, these are great, and I think they're really interesting. And as a researcher, we don't know if any of these things are really effective at reducing the burden of self-monitoring and increasing engagement or usability of this important behavior. So, there's some research, but really not that much. A study that was conducted a few years ago looking at MyFitnessPal, because that is the most popular app. I mean, they have, quote unquote, 40 million users, which, whether that people are using it consistently or just downloading it, but they have incredibly broad reach. I think that's the key takeaway. And so the study looked at among 200 primary care patients, will they use this app over 6 months, and can it be effective for weight loss? And so what they found is a very similar pattern, the same decline sharply within the first month, that they lost half of their users approximately in that first month, and that continues over time. And how they operationalize usage is really logging in at least once to this app. And I might argue that you need a little bit more than once a month to have some kind of effect on behavior change. So we know that paper and pencil has these challenges, approaches, even digital apps that are out there that we think are really cool and promising may have a similar challenge of just having too much burden. So our philosophy at Duke Digital Health is really to try and address some of these burdens. One, by making self-monitoring simple for the user, really simple for the user, so that we can have a consistent trajectory of self-monitoring. Aim for consistency and not detail and accuracy. We'll give up detail if we can get usability. And research shows that actually consistency is more important than really knowing if you had a tablespoon of mayo or a teaspoon. And then leverage existing technologies that can scale. As we heard earlier, there might be thousands of apps, but really only top 50 apps for diet tracking are being used. So we're trying to not create a new shiny app that can be and trying to get into the market with novelty, but really use technologies that people are already using every day, like text messaging, and I'll show you an example. And then design systems for interactivity. So we build our systems so that they can really be interactive. We always give feedback when data is received. So it's like this two-way communication, even if it's not coming from a human, it's coming from a computer. But it's this that you always give feedback, and a lot of these trackers don't necessarily do that. So instead of asking you to eat, write down everything you ate, portions, calories, and so forth, what if I just asked you this? Did you eat red meat yesterday? Could you answer that question? Does that seem fairly simple? And is that enough to maybe be effective, so that you know that you're supposed to be reducing red meat, and so did you do it or not? Or how many days this past week did you drink soda? That might be a little harder. You might not be able to figure out exactly the days, but you could make a little bit more inference than, say, whether you had a 12-ounce soda or a 24-ounce soda. And so that's what we're doing at with some of our approaches, and this is called the interactive obesity treatment approach. And it contains a lot of details that, like Sarah, I wish I could go into, but briefly what I want to talk about is that instead of having you focus on calories, nutrients, it focuses on these concrete, discrete behavioral goals. So we would assign you 4 behavioral goals. It's tailored to the person using our system. But all you have to track is, did you have cookies? Did you walk 10,000 steps? Did you drink soda? And did you eat fruits and vegetables? That's all you at any given time would have to be self-monitoring. And the goal is, the thought is that each of these potentially would create a caloric deficit. I don't know exact number, but enough to produce a pound of weight loss a week. So here's how it looks in practice. So the technologies that we use in our studies, and again, these are medically vulnerable populations, were text messaging and interactive voice response. So we send a prompt at a designated time that the user chooses, asking them to track how they did last week or yesterday on their 4 behavioral goals. They insert data, and then we give a feedback message that has a lot of logic behind it relative to how they did the previous week or how they're doing, so forth, with lots of different goals. And similarly with interactive voice response, and I'm just going to very briefly kind of allow you to listen to what it might sound like when our computer system would call somebody.
Now we're going to ask you about fast food. Use a number on your keypad to enter how many days this week you ate any fast food. Please enter a number between 0 and 7. Your track tip is drive by the drive-thru. That means no fast food. You said 5 days. You're doing better than last week. Remember to weigh yourself every day.
So you can see as an example of what that feels like and sounds like for the user. And so lastly, I'm just going to wrap up here is to show you that we actually, these are the results that we found. And we found this across numerous studies. This is just the track study that I'm presenting here. But this is our engagement with one of either SMS or IVR over 52 weeks. And that you see, just to give you a sense, our median completion rate is 94%. So that means more than half of the people engaged in this behavior almost every week over this year-long period. And we never got, except for at the end, and we could talk about that later, we never really went below 75% completion. So the trajectory that we're seeing with this approach is very different from what we're typically seeing in using apps or using more paper and pencil approaches to self-monitoring. So I know I'm over, and I'll end just with this question of, like, which would you want to use? Because it really does matter. The user is really what you would prefer. For some people, the MyFitnessPal works, but that isn't necessarily going to scale for the masses. And so what we're trying to do is really leverage technologies people are already using, and we think that this approach can really be impactful. So I'm sorry I'm over, but I want to thank our team at Duke Digital Health, and I'm happy to stick around for any questions. Thanks.
That's okay. All right. Thank you, Dory. It is so unfair to ask academics to give a 7-minute talk about anything. Sorry about that, guys. All right. So our next speaker is Dr. Charlene Wong. Charlene is an assistant professor in the Division of Primary Care here at Duke. She completed a pediatrics residency at University of Washington, Seattle Children's Hospital, fellowship in adolescent medicine, University of Pennsylvania, and Children's Hospital of Philadelphia. At Duke, she's going to be conducting research on consumer experience with accessing healthcare, impact of health policy on youth, and innovative strategies that leverage behavioral economics and technology to improve youth health and well-being. Today, she will present on vetting and evaluating usable mobile health solutions for teens in primary care. Charlene?
Cool. All right, thanks so much for inviting me to be here. I recently started at Duke in January, so it's just awesome to be part of this conference. So I'm going to change gears just a little bit. I'm giving tips on using mobile health really from an adolescent medicine pediatrician's perspective, because that's what I am, and also a budding behavioral economist. And I'm an academic, so I always put in a conflicts of interest statement. I don't have any conflicts of interest. And I just wanted to say that what I'm really going to be focusing on today are adolescents and young adults and their use of mHealth, because that's both my clinical and my research population of interest. And the reason I became interested in mHealth is because my patients spend even less hours per year in front of a doctor than, for example, some of the patients that Drew was talking about in the earlier session, because we know that adolescents and young adults don't use our healthcare system with as much frequency. But in contrast, they're spending over 5,000 waking hours making a lot of different decisions that are affecting their health over the next several decades. And also, importantly, forming these sorts of health habits that are either going to promote or be a detriment to their health long term. What else are they doing during those 5,000 plus waking hours? They're on their mobile health devices. And I joke that, or mobile devices, I joke that they're also using them, for example, while I'm trying to see them as in their primary care visits. And so with that in mind, I've been embarking on work, there we go, over the last couple of years, thinking about how to extend our reach, clinicians' reach, to adolescents and young adults, particularly for preventive care services. This is work that's been funded by the Maternal and Child Health Bureau, and that I'm doing in collaboration with folks out at UCSF. And we have written a couple of papers, and we recently workshopped this at an international conference of adolescent health providers. And people came up with many challenges to using mHealth with this population, but the top two that I wanted to talk about today are, number one, data privacy. So just as an example, in 2016, a bunch of researchers reviewed more than 200 diabetes apps. And diabetes has come up over and over again today. And 81% of those reviewed apps had no privacy policy. And of particular concern for adolescent providers like myself are particularly when there are a lot of apps that are targeting mental health. And so thinking about the privacy issues and concerns around mental health. The other thing that people identified was, and these were not people who were really into mobile digital health informatics who were sitting in this room, where they said, I really want to recommend apps and use apps in my practice, but I can't figure out which ones to recommend because there's this endless living and dynamic set of app options. How am I supposed to find a good app? So, there are people who have written about this in the medical literature, and, you can see all these different steps here that people might take. Well, the average practitioner doesn't have time to go through and do this. So what we did in this conference is we did a little app curation ourselves, and I'm just going to present some results from what we found to be the best apps for teen preventive care. Using the participatory approach, we had a couple young adults who were participants in identifying these apps, and then we also crowdsourced from this much larger audience of international adolescent care providers. And most of you in the room will probably know many of these. So MyFitnessPal, Dory came at the top of the list for exercise, and also Zombies Run, because zombies are so hot with adolescents and young adults these days. We do a lot of sexual and reproductive health as well, and our favorite period tracker app was one called Clue, and then for contraceptive options, an app called Bedsider. And then mental health, where we really identified some concerns around privacy, Headspace, which is a guided meditation app, and then Stigma, which is a mini short journaling app. We also compiled these practical tips for providers who want to incorporate apps into their practice. Primary care docs were given these 15, sometimes 10-minute visits, and we're supposed to cover a redonkulous list of things that we don't have enough time to cover. And so some of these tips to help actually make this usable for the providers. So one, demo them. So have the recommended apps downloaded on your own device to show the patient during the visit to make it more likely that they're actually going to do it themselves. You've got a captive audience because inevitably you've got to go print something out, wait for the nurse to get them the vaccine, something while they're just sitting in the exam room. So actually ask them to download their apps during that time. A lot of the clinics have Wi-Fi available now where patients can get on that Wi-Fi. And then all of us are required to give an after-visit summary. You guys have probably all gotten this kind of mumbo-jumbo printout that your doctor hands you at the end of your visit. Many of us use smart phrases and templates to build those because it's not like we're typing those pages and pages out at the end of each visit. So including your curated app recommendations in your instructions so that at least when they go home, if they didn't download it in the room itself, they might do it when they get home. I'm going to switch gears just a little bit because we know that giving patients devices isn't enough. You can see that in this figure here. We need an effective engagement strategy to increase the impact of technology on health. Now, one of those strategies would be to make it invisible, but that's not how it is quite yet. So the area that I've been exploring is behavioral economics. And this is a field that leverages the fact that we all make decision errors in our everyday choices, but they happen to happen in a systematic way so that you can design small incentives that may lead to big improvements in health. So for example, we tend to be more influenced by potentially losing money than winning money. So let me give you one concrete example. It also is in diabetes. This is a randomized controlled trial that we ran recently called Be in Control, Behavioral Economic Incentives to Improve Glycemic Control Among Adolescents and Young Adults with Type 1 Diabetes. In this study, we enrolled 90 participants who were 14 to 20 years old, and we gave them all these iHealth glucometers, and it comes along with an app on your smartphone. And we gave them all goals of checking their glucose at least 4 times a day, which is what they've been being told to do ever since they were diagnosed with Type 1 diabetes. And then we laid on top of that a financial incentive. and we made them loss frames. So they would start with $60 in a virtual account at the beginning of each month, and each day that they met that goal, they kept that $60. But if they didn't meet that goal, the next day, every day, they would get a text message that either said, awesome, you met your goal, you still got $60, or unfortunately, you didn't meet your goal, you have $58 remaining. And the finding that we had here was that we actually saw a change in behavior. So the green line is our intervention group, the one that had those financial incentives. And you can see that they had a much higher rate of meeting those glucose monitoring goals during that first half when they had those financial incentives. It did unfortunately tail off, so thinking about how to sustain this, but just wanted to give that as one concrete example of laying behavioral economics on top of mHealth to increase engagement and increase the impact. Thank you so much.
All right, thanks, Charlene. Our final speaker is Dr. Hayden Bosworth. Hayden is a health services researcher and associate director of the Center for Health Services Research in Primary Care at the Durham VA Medical Center. He is also a professor of medicine, psychiatry, and nursing here at Duke, and adjunct professor in health policy and administration at the School of Public Health at UNC. Today, he'll be presenting on usability in healthcare technologies.
Did we figure out how to do this? Oh.
Yeah, yours is
That. Okay, that looks like. Oh, ooh, cool. Now we just need to make it happen. Okay. Oh, going the wrong way. Well, hold on. Let's see. Sorry. All right. How do I get to the full screen? What's that? No. All right. Well, given that I probably now only have 6 minutes. Okay, here we go. So I wasn't really sure exactly. I asked for advice on what I was supposed to do, so I'm going to be different than the other three. I'm going to just look at from the outsider's perspective, looking in and comment on some of the issues that I think are going on. I'm going to ruin the story, and basically I work in the context of medication non-adherence. So we have identified 100 factors that are related to non-adherence, and there are also different stages. So I think one thing that I took as the last speaker so far in this panel is we can do things and move it and improve results for periods of time. But the question is in the context of, let's say, weight or medication adherence, these are chronic diseases for the most part. How do we keep these things moving so that people are doing this for years? Okay, and how do we make this sticky? And so I think the end result will be we need a toolbox. There is not going to be one solution, not one mobile technology that is going to meet everybody's needs. And so how do we use good methodology to adapt it and change it as people move forward? So I'm done, basically. You can leave if you like. So this is what we want to think about mHealth according to the industry, okay? And most of the work I do is in chronic disease, so generally older adults, 60 years of age and so forth. But this is what's really going on. You already saw this, okay? But you know, a lot of what we've done is kind of the low-lying fruit. We really have not got up to the premium fruit, really thinking about how do we integrate this. We have, in the context of adherence, we have our clinical data, we have our pharmacy data. None of those two really talk to one another unless they're an integrated data set. But if I was to ask you, if I had time, I'd ask you, what are the factors that are related to non-adherence? Well, risk, benefit, side effects, cost. Show me a database that has clinical data and pharmacy data that has that information, okay? So surprisingly, when we look at these data and we think of big data and predictive analytics, lo and behold, we're not really doing a pretty good job of figuring out who are adherent and who's non-adherent, let alone matching what the intervention should be, okay? So, you know, insanity is doing the same thing over and over and over again. And I think this is some of the things that we can see that are happening. We get a really cool device. I sit on a study section for SBIR and SCTR. These are business grants. You have an engineer who creates this really, really cool device. No idea what the cost implications are, let alone who are going to use that device. And so you have something that's useful in one context, but never thinking about where I put that, how is going to use it, who's going to pay for it. So as we think about these things, we really have to think about how does it get integrated, how is it used in the healthcare, and how does it close that loop so that the physicians see this information. So that's another thing to think about. So we are, this is my attempt to look, we're looking under the light, this is all the cool stuff there, but in reality we really shouldn't be, maybe we need to look outside our comfort zone and really understand through participatory what is going on, what are the needs, and meeting them there. So this is really hard work. And I just put this there as kind of some of the work we've been doing. And it's really thinking about multimodal engagement, integration of the data, segmentation. We talk about targeting and tailoring. So again, back to adherence. If I know there's 100 factors related to non-adherence, in general, there are about 5 big buckets that explain non-adherence. So maybe I can solicit, do you understand your medication? No? Well, then I can tailor the information to where you are. If you do understand it, and I always use the analogy from my son, who at the time was 5, the Winnie the Pooh phenomenon. He asked me, what are the birds and the bees? I said, oh my God, 5 years old, coming and asking me about what the birds and the bees are. I'm going to emotionally scar him. My wife is smarter, she's a child therapist, and she said, no, ask him what he thinks it is before you assume anything. It's kind of that basic fundamental of shared decision making. He was just interested in Winnie the Pooh. It had nothing to do with that. So when we think about these programs, we can't just assume that people are non-adherent. There may be reasons for it. Understanding what they are. So I think, again, the tool is mobile health is a tool, but it's not going to remove some of the shared decision making, the interaction that has to happen in some ways. So this is just a schematic. This is the patient journey. I think we create these really, really wonderful designs. And then user experience, okay? And people are laughing. I guarantee you that anybody, if they're really honest, the best things I thought really worked, somebody figures out a different way of totally misinterpreting it and doing something entirely different. And so really working through that. But are you going to get it right out of the gate? No way. So you need that iteration. How do I do methodology that allows me to iterate, change it, but yet maintain that fidelity? So we have to still think about that methods to allow us versus doing a trial for 24 months or whatever period of time, those of us that live in academia, and worrying about the fidelity. That's crazy. There is no reason we should be doing that, and that's a waste of money and time. So just understanding, patient experience is not linear. These are just other pieces that you can think of. And again, you keep coming back. It's the content that will always drive where we go. It's not going to be the methods or the methodology. So in terms of trying to wrapping up, I think we're seeing modest effect sizes. It's not surprising because we really are trying to fix one solution for everything in many cases. And we get some uptake, but show me something that's results that are 12 months, 24 months, 36 months. How many of you are using Pokemon Go at the moment? Came out in July. 2, 3. Me, 4. Okay. I mean, so how do you make it sticky? Well, the only reason why it's sticky is my son wants to play with me, and that's the only way to keep him engaged is he talks to me and asks me what I'm doing. So, but, you know, thinking about these opportunities, how do we keep these things going is really important. So, you know, no matter what we're doing, I think in the end, it's also the health is our outcome, and then it's also one size isn't going to fit all, and I really do think it's going to be a combination of multiple factors are going to be what we need. I already mentioned the continuous care optimization, this idea that we could put in every 4 weeks, we'll do some type of formal evaluation, change it. And if it's not working, then give something else. Even similarly, allowing people to choose text messaging versus IVR. We know older adults prefer IVR. Same content, but just allow them to use different modes of how they want that information. And I just think also it's important to put into perspective health plan and who's going to pay for it and reimbursement. So we can do all these two-way multimedia communications, low cost, but small effects. So trying to also segment so that we can use mobile maybe to do it for large pieces of the population, but then how do you scale? Maybe then you figure out using that information to trigger when somebody needs a nurse or a higher level intensive intervention. So trying to incorporate that as well. And then the goal is really engaging patients wherever they are in whatever way they want. And in terms of wrapping up, I just want to do a plug for the new Department of Population and Health Science that will be going online in July. We will be having a major focus on dissemination and implementation. I think some of these are methods there. I also think you have 4 panelists that I believe are all in academia. The academia has a beauty of allowing us to do some really cool stuff, but if we don't partner with our friends in industry, we're going to get really cool stuff that gets published and nobody ever uses it. So really thinking about how you partner those things, because they have their own issues. And doing a trial of 400 is very different than a trial of 40,000 people. So thinking about those methodology. And then I just think in the end, also not only your toolbox, your content, it's really developing really strong research methods that allow you to evaluate that. And good science will always be important, and not just simply the shiny new object that comes out. So thank you.
All right, thanks, Hayden. You raised a lot of provocative questions and summarized a lot for us. I've been told that we do not have time for discussion, which I really hate to say. Is that not true, Erica? Yeah, we can take one question. It better be a good one. Who's got the best question? Maybe I put too much pressure on you now. It doesn't have to be a very good question at all. Awesome.
Thank you so much for that talk. 7 minutes, a little bit longer. Listen, I want to say something about what your focus has been. So the question is, what level of resources have you all marshaled to serve and extend the clinical sequences into the caregiver's life? Because so much of our digital stuff is focused on the caregiver's age, practices, and imagination. So I loved your slides with the older people slamming their phones. But maybe digital health really needs to be addressing the needs of the caregivers too.
Yep.
Thank you.
Yeah.
I agree. I don't. It wasn't it was more of a comment, I guess. But I think that's. If I had 8 minutes, I could talk about ecological perspective, because the patient is the center, but how do you frame it within the family, the caregiver, the healthcare system, the insurer, the payer? And I think we need to do that. And the more pieces we integrate, and that was what I was referring to as closing the loop, the more better outcomes we actually see. And that closing that loop, however we do it, is crucial, because patients really will more likely to engage if they know somebody on the other end in the healthcare system, whether they're also as well as their family, are using that information. We get better outcomes.
So we think a lot about caregivers in adolescent and young adult medicine, because most young people are still living with their parents or other guardians. In our study, actually, we found that we were really targeting the young person themselves with, for example, these financial incentives, giving them the glucometer. But actually the parents were loving this, because by the time that these young people reach adolescence, the reason we focused on this group was because that's the age group I focused on, but also in diabetes, we see them fall off this cliff, because as they get older, they're supposed to be taking more independence for doing their diabetes care, and sometimes they can't manage to figure out how to do that. And so by the time we came in with the study, many times the adolescents and parents have been butting heads like this, because the parent has been asking them every day, what were your glucose readings today? Did you check your glucose? They're trying to find their glucometer to see. With this app, you could, the parents could ask them to just text them their last 2 weeks of glucose readings, last day, last week, however you wanted to cut the data, and they could text it. The parents also could make an account on the iHealth website, so they could go in and just see it themselves without even having to ask their daughter or son to do that. So, and then the providers liked it, because even though we talked about how to integrate this into clinical care, and it is a parallel system, as I forget which speakers talked about that, but the graphics were so nice on this that it gave the provider what they needed to know. Like, are you mostly in range? Are you mostly way out of range? Are you somewhere in the middle? And then if they needed to, they could go into more detail. So in our case, for this one project, we actually did see that it kind of touched all of those other pieces of the young person's life.
Great. All right, thank you. All right, thanks, panel.